After the patient is placed in lithotomy position, we introduce a speculum, one anteriorly and one posteriorly, visualize the cervix and hold it with the valsalum at 12 o'clock position. Now we are going to inject ICG dye at 3 and 9 o'clock position. Here we have to understand it needs 4 injections, 2 at 3 o'clock and 2 at 9 o'clock position. 3 o'clock we are going to inject one superficial and one deep, that is 1 to 2 mm depth and 1 to 2 centimeter depth. Similar thing done on 9 o'clock position also. Because of the depth, spinal needle is preferred. After the injection of the dye, we are going to make an entry into the abdominal cavity. This is our standard port position that we use for laparoscopic hysterectomy. We are going to lift up the round ligament and take a cut on the peritoneum on the lateral wall. Now this peritoneal cut is deepened in order to expose the external iliac artery and the vein. It is important to create small windows and be gentle with the dissection so that lymphatics are not injured. As we can see, the external iliac vein is being swept away in order to expose the internal iliac area. Now we can see in the video one of the lymph node which has taken up the dye. Now gently this node is dissected, taking small cuts superficial to the node. As we can see, because of the ICG dye, we can see a very clear distinction between the node and the surrounding tissue. Here it is important to be careful because we can see medially there is a obturator nerve which should not be damaged. Now we have taken the node completely and separated it from the surrounding tissues. It's also important not to injure the lymphatics and take out the node intact, because once there is a injury to the lymphatic, the whole area becomes green. Now we have separated the first node, the sentinel node, from the internal iliac artery as well as the obturator nerve. Now this node is kept separately. Further we visualize and we see that there is one more chain of small nodes which have taken up the dye near the obturator vessels. As we can see, the color contrast between the green of the node and the normal tissue is very obvious, so that makes the dissection easier. Once again, it is essential to stay very close to the node to avoid injury to the surrounding lymphatics and the surrounding important structures. So this is the area of the corona mortis where without injecting the dye, dissection can be tricky and can lead on to bleeding, but here we were able to dissect the nodes out without injuring. Now we could see that there is one more lymph node which is situated at the origin of the uterine. Here the vessel that is seen is the uterine artery arising from the anterior division of the internal iliac artery. Once again, we hold the node and dissect it off from the surrounding structures. This node is in very close proximity, and what has been observed in the studies is that this is one of the most common location of the sentinel node. In this case, we did the similar procedure on the opposite side, and this is the final picture. We sent the nodes for the frozen section, and on frozen section the nodes were found negative. So this is the final picture. Now if I compare it with our routine pelvic node dissection, where as we can see, all the vessels, nerves and the ureter are completely bare, and we have removed all the fibrofatty tissue, nodes as well as the lymphatics also. So we can see a very clear difference between a sentinel node biopsy and the node dissection.